You are in the ED, and your next patient is a 3-year-old boy with a history of 2 days with URI symptoms. Yesterday, he spiked a fever and mom noticed barking cough. Vital signs are stable, has a temperature of 101. On exam, you find the kiddo has hoarseness and inspiratory stridor with crying. Rest of the exam is normal. This is a typical case of viral croup. What do you do next? In the next video, I'll tell you what you really need to know about viral croup. As presented in this case, croup typically occurs in children 6 months to 3 years of age. Symptoms usually begin with nasal discharge, congestion, and coryza, and progress over 12 to 48 hours to include fever, hoarseness, barking cough, and stridor. There is minimal, if any, pharyngitis. As airway obstruction progresses, stridor develops, and there may be mild tachypnea with a prolonged inspiratory phase. The symptoms typically resolve within 3 days. Now, straight to the point. What should you do next? The evaluation of children with suspected croup should focus on 3 steps. The first one is prompt identifying patients with severe airway obstruction or those at risk for rapid progression of airway obstruction. Let's talk about identifying if your patient needs an emergent intervention. First, do a rapid assessment of vital signs, pulse ox, look for the presence of stridor at rest, mental status, and check if there is an impending respiratory failure. Also, you should evaluate who are in high risk of rapid progression of airway obstruction. Be careful with those who have sudden onset of symptoms, rapidly progressing symptoms. For example, symptoms of upper airway obstruction within 12 hours of illness, previous episode of croup, underlying abnormality of the upper airway, and medical conditions that predispose to respiratory failure like neuromuscular disorders. Also, be very careful when evaluating these kids. You must do it to make the child as comfortable as possible. The increased inspiratory effort secondary to anxiety and fear in young children can exacerbate subglottic narrowing. Now, your second step is to exclude other conditions with similar presentation. Let's see. There are some clues in the history that are helpful in distinguishing croup from other causes of acute upper airway obstruction, like the absence of fever is suggestive of spasmodic croup, difficulty swallowing, which may occur in acute epiglottitis. Drooling may occur in children with peritonsillar or retropharyngeal abscesses, or in epiglottitis too. There was an observational study where they found that only 10% patients with croup had drooling. Throat pain is also less common with croup. And all these 3 are very common in epiglottitis. Okay, now that we know your patient is not an impending respiratory failure and that you ruled out other causes of upper airway obstruction, the next step is to assess the severity of symptoms. There are many scoring systems to assess the severity, but the most known is the Wesley score. This is one of the most important things you should learn, because knowing the severity of your patient lets you decide what is the best next step for your patients, either in exams or in the real life. The Wesley score evaluates the presence of stridor, air entry, retractions, presence of cyanosis, and level of consciousness. It's not necessary that you memorize the score, of course, but at least that you remember the different typical findings in each group. Let's see. Patients with mild croup, the key is that they don't have stridor at rest, although stridor may be present when upset or crying. They have occasional barking cough and mild or no retractions. Patients with moderate croup have frequent barking cough, the stridor is at rest, and they have mild to moderate retractions, but there's little or no agitation at all. Patients with severe croup have significant stridor at rest, although the loudness of the stridor may decrease with a decreased air entry. Retractions are severe and the child may appear anxious, agitated, or pale and fatigue. Patients with impending respiratory failure have fatigue, marked retractions, decreased or absent breath sounds, depressed level of consciousness, tachycardia out of proportion to fever, and cyanosis or pallor. Now, let's talk very briefly about management. First, supportive care with fever control, mist, supplementary oxygen, fluids are beneficial for everybody. Mild, moderate, and severe croup all benefit from dexamethasone. Moderate and severe croup should receive RAC epi naps. And when are you going to admit the patient? Moderate croup with persistent symptoms after initial treatment, severe croup, patient requiring fluid or oxygen, toxic appearance, and also consider admission if the patient is less than 6 months. Finally, let me talk about imaging. Although it's very common to be mentioned in exams, X-ray confirmation of acute laryngotracheitis is not required in the vast majority of children. It's only indicated if the diagnosis in question or there is an inhale or swallow of foreign body suspected. Anyway, let's talk quickly about the radiographic findings, which are very common in questions on exam. In children with croup, a posterior-anterior chest X-ray demonstrates subglottic narrowing. This is called steeple sign. The lateral view is described as an over-distension of the hypopharynx during inspiration and subglottic haziness. The epiglottis should have a normal appearance. In contrast, the lateral X-ray in virtually all children with epiglottitis demonstrate swelling of the epiglottis, sometimes called the thumb sign. And the lateral X-ray in children with bacterial tracheitis may demonstrate only non-specific edema or intraluminal membranes and irregularities of the trachea wall. Well, this is what you need to know about viral croup. I really hope it was helpful. Thank you for watching.